On behalf of AvicennaSociety, I appreciate this opportunity to present to you the transcabinet approach for spinal fusion. As you know, spine is now #1 reason for disability worldwide, and this problem is increasing worldwide globally, as well in many developing countries. By the time we are 50 years old, there's only 31% chance we don't have spine problem. By the time we are 60 years old, that drops to about 6%. And by the time we are 70 years old, there is 1 to 2% chance we don't have spine problem. And since population in entire world is getting older, this become a very common problem. I'm happy that not all these patients need spinal fusion. As a matter of fact, we have developed methods to minimize number of the people who need spinal fusion, but percentually that number is increasing. As a matter of fact, in the United States, over 1.62 million instrumented spinal fusions are performed annually. Vast majority of them still traditional way, which adds to the complexity, but as well to the cost of the healthcare. This is a public health issue. Now, when we look at the open surgery versus minimal invasive, I want you to understand that it's not about the skin incision. What happens under the skin is make a surgery minimal invasive versus open. As a matter of fact, lots of people call their own surgeries minimal invasive, independent of what actually is being done. What I think is important is that in this kind of surgeries, we spare the muscles. In a regular surgery, we detach the muscle from their origin, and those muscles are not only rendered useless, but as well, these muscles that are floating cause significant problem along the healing process, and this patient take a long time to rehabilitate from their surgery. And as well, these muscles are multisegmental, something we don't say to our patient that even if you do a surgery on one level, many of these muscles go many levels above and below, and the recovery becomes much, much harder as well, because by cutting the origin of a muscle, we disrupt the autoregulation of that muscle. This as well adds significantly to the recovery from spine surgery. So two elements that I think are important in a minimal invasive spine surgery is that we keep the muscle and their autoregulation intact during the surgery. This study is from 1930s that shows the vascularization of the bone is through surrounding muscle. There is no artery of L4. But by going posteriorly and disrupting entire muscle attachment to the bone, we are practically reducing the vascularization of the bone to a fraction of the original value. This is a patient of mine. In 2012, I did a 2-level TLIF. In 2014, I did the adjacent segment OLLIF. And as you see in the area that I did open surgery, all the muscles are scars, whereas in the area that I did OLLIF, the muscles and the tissue are pristine. By the way, on the bottom of the screw that I placed, you see that the bone is actually growing so much better. Now, this patient had 2 years after the last surgery, auto accident, that I had to take the patient back, and that is how I took this picture. Here in this picture, you see posterior aspect are actually all scar. Here, this is scar. This is a regular muscle. And you understand that this is not conducive to any kind of healing. As a matter of fact, if you compare here, a patient got a L4-5 regular surgery. In that level, all the muscles are scar, but even 2 levels above it, multifidus muscles have turned into scar. As well, I think what makes a minimal invasive surgery is the time under anesthesia itself. I saw a very good presentation that stating no matter what you do, if your surgery is 4 to 6 hours, there's nothing minimal invasive about it. This study, based on almost 400,000 patients, shows that every additional half an hour under anesthesia adds 17% to the combined risk of the surgery. And the math works in a way that surgeries below 2 hours have half the risk of surgeries above 2 hours. So time we spend under anesthesia in the OR should be optimized. It's not about the speed, but independently, the time under anesthesia adds to the complication rate of the surgery. Now, obviously, for a long time, we have done multiple different approaches from the back, from the front, from the side. And I want you to understand that today I'm not going to talk about OLLIF or oblique lateral interbody fusion anterior to psoas, but we are going to talk about oblique lateral posterior lumbar interbody fusion that is practically in prone position and goes through the border between the posterior and anterior element. The last third of the surgery is in the retroperitoneal space. In this specific surgery, we use 2C-arm neuromonitoring. It's all percutaneous. There's another version of this procedure that we use endoscope to enter the disc space. That is generally in the United States called Cambine or KLIF, Cambine lumbar interbody fusion. In the OLLIF, what's important is that we use 2C-arm, you use neuromonitoring and not endoscope to identify the nerve root. And as well, the efficiency of the OLLIF is what very attractive in my practice. Now, we have published many papers, and here is a list of them, which you can take a picture and go and look at them. Meanwhile, I have done over 1,600 of these surgeries by myself on over many thousands levels, and our experience is what I'm going to present to you. And I think the efficiency is extremely important here. More than 40% of our surgeries these days are done under 1 hour, and more than 90% of our surgeries are under 2 hours. As a matter of fact, one of the criteria to do a surgery in the United States is the time under anesthesia. Generally, we want to keep it below 3 hours. And as you see, I can do most of my surgeries in my surgery center because the time under anesthesia allows that. Obviously, there are other factors that are important here. And in comparison, I want to show you what the reality is here in the United States. On the right side, you see a 2-level ALIF, which is anterior-posterior fusion, based on the certain requirement of in the surgical theater. There are 6 and 9 hours. Obviously, 45 minutes of that is anesthesia. In the same time, on the left side, you see we perform a procedure that's as well anterior-posterior because our cage goes through retroperitoneal space with the same codes. Those surgeries are under 1 hour. And if you think that is now inefficient, this is a reality still that the 1-level fusion sometimes can take 5 to 7 hours. I think as a society, we need to agree that in 2024, 1-level fusion should not take 7 hours. And there are better ways of doing that. This is a study we published from all patients in one hospital. As you see, the blue line is a regular TLIF, and with the higher BMI, the time under surgery goes up, and the time under anesthesia directly correlates with the risk factor associated with surgery, including cardiopulmonary events. And as you see, the red line, which is a MIS TLIF, is a very efficient in trained hand. That is important. Initially, the learning curve can be very steep, but eventually it can be good. But once the complexity of the surgery goes up, multi-level, in this case, BMI, you see at BMI 37, it becomes more complex than open TLIF. As you see, OLLIF performs the same at BMI of 20 versus 45. And another study shows that even on BMI up to 60, we still can help the patient very efficiently. 96% of my patients ambulate within the first 24 hours, and I think that's important because I can't send them home when they're successfully ambulating. And here you see that the statistic of our surgeries in compared to TLF, which enable us to provide this care to broader group of people, especially in countries where resources are scarce. That adds significantly to efficiency of medical spine care to provide care to public. Now, we have a lot of data about additionally time under anesthesia, time of the surgery itself, discharge from the hospital. All of those are actually published. But I think it's important to understand that based on our observation and other minimal invasive, truly muscle sparing fusions as well, have confirmed that the fusion rate is extremely high compared to other procedures, because again, we are saving the muscle that supply blood perfusion to the bone. Now, in short, this technique is minimal invasive, very efficient, very little blood loss, single position, and as well, it enables us go from some variation from T6 to S1. Certainly, there are some variation of it that you have to learn, so you can apply it universally to many situations. And I want to show you as well, the Cambin triangle and the borders of it. And I think what's important to understand is that the nerve root is attached to the pedicle of the level above, and even in very collapsed disc, this still can be extended by a dilator, in a method that enable us to safely perform the surgery. The protocols that we have put together are very important. We use 2C-arm that give us real-time position of all our instruments, and that enable us to be extremely efficient. We target the middle of the disc in the AP and lateral, and then we use a neuromonitoring probe to enter the disc. We stimulate first at 3 milliamp, then at 4 milliamp. There is this neuromonitoring probe is insulated all the way to the tip. Then there is a metal sleeve that goes over it. Over that metal sleeve, actually a K-wire, and then a dilator goes in, a tube goes in, and it's all about the certain tools that enable us to do the discectomy and prepare the end plate. Now, this is what I think is important. What you see here is everything that you need to perform the surgery. You don't need 6, 7 different sets and complex retractor system. You need this handful of tools to perform the surgery, and I can take it in a small bag to any small town in Africa or Asia or anywhere to perform the surgery. Once you get used to these tools, you can perform a discectomy very efficiently. There's a video I want to quickly show you the actual steps of the surgery. And here, as you see, the nerve root, the disc, the Cambin triangle. And then here we actually use a neuromonitoring probe after we do our measurements. Here you see the X-ray machine going back and forth, but we don't do that anymore because that takes a lot of time. Once we identify the anatomic middle of the disc, we go at 45 degrees so that we are practically have a best approach to the disc and Cambin triangle. These days, I aim for the pedicle of the level below, and I literally drop the monitoring probe into the Cambin triangle by running it over the actual pedicle of the level below. Once we are in the right place, obviously, the neuromonitoring is what enables us to do this surgery very efficiently and safely, because if the neuromonitoring probe comes close to a nerve, we can get the signal and reposition it. And anytime I hear, what do you do if there is a conjoint nerve? Obviously, then it doesn't really matter. The neuromonitoring probe will tell us if that window of approach is safe or not. But once we are there, we literally put the the K-wire in. We use a dilator, and that is extremely important. The cage and the dilator work in synchrony. The cage is its own dilator. At first, we put the dilator in, we put the access portal in, we literally perform the decompression of internally decompress the disc, remove the material with a series of tools that are very efficient to do the job. And as you see, these tools are especially designed to work over this tube that is 8 millimeter inside and 10 millimeter outside. Once we perform a discectomy and prepare the end plates, then we are ready to, first of all, pack that space with biologic. And then once the biologic is introduced to the disc space, we are able to then put the cage in. Here's another tool that you're able to see And again, these are very specialized tools that mostly we have designed to exactly do this. Here you see introduction of the biologic. It's important the biologic that we use is a very special tricalcium phosphate granulates in a collagen matrix. It behaves in a certain way that it's really conductive. We mix it with bone marrow that is taken from one of the pedicles after Jamshidi is placed. And here you see a PEEK interbody graft placed. These days we don't use PEEK anymore. We use a titanium cage. But in the AP and lateral, obviously, we confirm the positioning and then we are ready for the next step. I want to show you as well a few of the videos that show the actual process in the X-rays. And here we are going to, I'm going to just go quickly over it. The K-wire is placed. And then obviously I put the Jamshidi in. The Jamshidi helped me to get some bone marrow. This is the neuromonitoring probe that helped me to go in, get the right access to the disc base. And then you see a series of tools that help me to perform a discectomy, prepare the end plates. And here you see the cage being placed. Practically from the beginning of the surgery to this point is usually less than 8 to 10 minutes. And then the rest of the surgery is placing the K-wires, pedicle screws, and then finishing up the surgery. Generally, a one-level fusion is done in less than 40 minutes. Now, once you can repeat these processes, you can do complex cases. Here you see that the osteophyte, how far they are practically distracted. And by putting the cage right and left, front and back, you can actually correct sagittal and coronal deformities. And if the fusion happens, it has been a big question. And I can answer that to you with a very sound yes. The end result is multiple small incisions that the patient really recover fast from. And these are statistics for a one-level fusion. Obviously, this is last year's statistic, and we constantly are improving. You can repeat the steps, and then you're able to do this kind of pathology, treat this kind of pathology to this on the patient that has very small resources, reserves, and where other surgeries are absolutely not an option. Now, this surgery was done in less than 2 hours with about a cup of coffee of blood loss, and these patients are able to go home so much faster. Now, I want to tell you, if you have any question, you want to see actually the process in cadaver lab, please take this barcode, take a picture of it. That takes you to YouTube where you can see the actual surgery. Well, I want to thank you for this opportunity, and I hope that we see you soon in one of our society meetings.